All right, good morning, everyone. My name is Nicholas Stevens. I'm an undergrad at Penn, pursuing degrees in engineering and business, hopefully becoming a grad student in a couple weeks. I'm here to represent a team of 4 undergrad engineers, which 2 years ago embarked on a project to reduce the vital sign monitor alarms in ICUs nationwide. I'm also joined today by our advisor, Margie, who's going to introduce the project by talking about the problem that motivated it.
Thanks. Thanks, Nick. And I want to thank the Center for Bioinformatics for having us here today. I have been a nurse for 31 years, so for those of you who are counting and interested, yes, I am 31 years old. I don't know why you're laughing, but we'll move on. Out of those 31 years, I've been a critical care nurse for the last 15 years. And critical care units are extremely noisy. Practitioners use a variety of medical devices to support the patient. And each of those medical devices has their own set of alarms. And so practitioners every day respond to various beeps, buzzers, and at one point, we actually did a study in one of our units where we took a look in a 12-hour period of the number of alarms that we get. And in that 12-hour period, we got over 2,100 alarms. Of those 2,100 alarms, about 10% are clinically relevant. And so there's been a lot of discussion in the literature recently around patients' safety because many times we don't respond to those alarms because it's a cry wolf syndrome where there's just so many alarms that after a while we start to not hear them. And so actually, when I first started nursing, and even to this day, when we talk to practitioners, you'll hear them say the alarms are pretty much nonstop. I know where the silence button is, and I still hear them in my sleep. I'll still get up at night and thinking I have to turn that beeper off. So. Working at the University of Penn in the Department of Nursing, it's been encouraged that we branch out and begin working with other disciplines. And so I've been working with the School of Engineering now for about the last 2 years. And we're looking at partnering with engineers on developing different medical devices so that we can respond to these alarms a little bit better. And that's where Nick and his team came in, and together we sort of looked at this problem, and Nick and his team came up with a new set of alarm systems that he's going to talk to you about now.
Great. Thank you, Margie. So from an engineering perspective, this is staggering. If you haven't been in an ICU, when you walk in, these alarms are going off all the time. And the fact that 9 times out of 10, a nurse is responding to alarm only to realize that her presence in the room is not necessary is even more amazing. So the next logical question from an engineering perspective is, why is this the case? And the answer is actually quite simple. And I'll use this sample patient, falsified name obviously, to explain why this is the case. So we have Mr. John Nava. He's based on a real patient at Massachusetts General Hospital. He had a CABG surgery, which is coronary artery bypass graft surgery. And after, in the post-op period, he's plugged into up to 8 individual vital sign monitors, 4 of which are shown on this screen. Then the attending clinician will program these monitors to alarm when certain thresholds are breached. So, for example, right now, Mr. John Nava's respiratory rate is a tiny bit high, so a respiratory rate high alarm would be going off. Similarly, his heart rate is a tiny bit low, so a heart rate low would be going off. So in this instantaneous moment, 2 alarms are already going off. Yet what's surprising is that when a nurse actually walks into the room, she's not just looking at one respiratory rate monitored by itself. She's looking at all the vital sign monitors together and the patient himself. So the logical question is, if the nurse is doing this 100 times a day, why can't the machines? And that brings us to the goals of this project. They're threefold. First, we want to build an algorithm that considers multiple vital sign monitors instantaneously. Second, we want to decrease the total number of false alarms by at least 25%. We want to make a dent in the workflow of these clinicians. And third and finally, we want to make a new, more efficient and clear 3-level alarm priority system that accurately communicates the severity of the alarm at hand. So from an engineering perspective, we endeavored to create this machine. It takes inputs from 3 different vital sign monitors, which output 4 individual vital sign measurements. It combines this with all the medical context that is available, like what operation they just went through, as well as their prior medical history in electronic format. Then it uses something called fuzzy logic, which I'll explain in a little bit, and Bayesian analysis to output a singular alarm in 3 forms: the alarm you hear, the alarm you see, and then also a third component, which we call the CDS, the clinical decision support. For some reason, the slide is missing from this presentation, but we passed this algorithm through 1,400 hours of medical data, or 32 patients, and found that we reduced the total number of alarms by 59% with a standard deviation of 17%. So already off the bat, just this simple system which combines all the vital sign monitors together was already making a huge impact. So the next logical question is, you're obviously not a medical expert. How are you coming up with these rules? And that was based on the extensive interviews with clinicians in the Penn hospital system. And what we were asking them about first is, for each of these vital sign values, what would you consider to be a normal range? And further, what is abnormal? Also, if you have a combination, maybe blood pressure is abnormal, then everything else is normal, do you want an alarm? And if so, if you want an alarm, how severe is it? Should you be running, should you be walking, or do you just want a notification? The algorithm uses something called fuzzy logic, which is based on the premise that while computers are discrete, they work in ones or zeros, absolutes, our real world is far from it. So the common example people cite is, if you have an apple and eat half of it, you can't just say you have an apple, you can't say you have a core, you probably have half an apple. And we find that vital sign values work in the same way. It's not high or normal, it could be slightly high. So this is a graph of respiratory rate with the respiratory rate along the bottom axis, anywhere between 0 and 35 breaths per minute. Through interviews, we found that, let's say the person is breathing at 15 breaths per minute, that's unequivocally normal. But if you get up to 23 breaths per minute, for most patients, that's somewhere between a normal and high, or what we term as slightly high. So if you gather these data sets or these stepwise functions for every type of vital sign monitor with every type of patient, you start generating these rules when we put them together. And so a good example is, let's say you have for a patient a slightly high respiratory rate, but everything else is normal. Time and time again, clinicians told us we do not want an alarm, even though in the hospitals you'd obviously get a respiratory rate high alarm. So for our algorithm, the alarm resulting level is 0 out of 3. We validated this system after building the algorithm through 1,400 hours of medical data that is available through PhysioNet. It's a conjunction partnership of MIT and Massachusetts General Hospital. And then we've also begun shadowing clinicians in the Penn hospital system, not only watching and seeing what they actually do in the ICU in real time, but also we built this app where clinicians can walk through real patient histories and experiences and decide whether an alarm was necessary or not, which further validates our system. Yes, here's the resulting slide. I am now going to play a live demo just to hopefully communicate the difference our algorithm brings to an ICU. This is again a real patient data with a falsified name. What I'm going to do is play 20 minutes at a very accelerated rate. Every time the screen updates, that's a minute gone by. And first I'm going to play this video through the old hospital system. So already he's breathing a bit quickly, a respiratory rate high alarm is going off. His heart rate dipped down a little bit. There was another alarm. Now there's another heart rate low alarm, and the nurse is getting up out of her chair, going into the room, and finding that, the heart rate can't actually be 0. Everything else is within normal range, so she's plugging the lead back into the person. It must have fallen off and leaving. Now the lead is plugged back in, some significant events start happening, the blood pressure is dipping, and a clinical intervention is necessary. So that was just 20 minutes, and already 8 alarms were going off, only one of which was clinically necessary. Now here's the same 20 minutes using our new alarm algorithm. Silence. The respiratory rate might be a little bit high, the heart rate might be a little bit low, but a clinician doesn't want alarm for that reason. Now the heart rate is once again low, but since our algorithm looks at all the vital signs in conjunction, we know the heart rate can't actually be 0, and we're firing a very specific malfunction alarm. Hopefully you can hear the difference. Now the lead is plugged back in, some actually medically relevant events are happening, and the first real smart alarm is going off. It's a level 2 alarm, and the nurse knows that her presence in the room is necessary. The final component of our algorithm is what we term the CDS, which aims to combine the instantaneous vital signs a patient is going through with the potential complications that they might experience in order of likelihood, and then also present their relevant risk factors based on the operation they had and their medical history. So a good way to explain this is, again, with an example patient. We'll call him patient X. He just went through a CABG surgery, again, and these are the 11 possible complications he might experience in order of likelihood as based on the medical literature and extensive interviews. You'll see as different vital signs are displayed on the screen, a lot of these complications will be removed because they're not medically possible. So blood pressure high, a bunch are leaving, heart rate low, SpO2 is normal, and respiratory rate is normal, leaving us with only 3 potential complications in order of likelihood. Also, this patient happens to be a smoker, has a history of heart disease, and diabetic. And all of this would be easily displayed on the same vital sign monitor a nurse is already interacting with. And the point of this is not to diagnose patients. We're not claiming we can do that. But since a nurse is often dealing with multiple patients in an ICU at the same time, this hopes to just remind her of what the patient might be experiencing every time they respond to an alarm. So the road ahead is threefold. First, we're obviously wanting to validate and make sure this works with nurses. The key thing we're worried about is if a quieter ICU actually helps nurses. Sometimes they do want alarms even if they're not relevant. So we're interviewing people like that. We're also, we found out that while we focus on CABG patients specifically early on, this can be extended to all types of ICU patients, ranging from young gunshot victims to the old, often CABG patients. So we're extending and testing that. And third and finally, we've been lucky with a couple grants recently. We're trying to figure out a way to actually get it into hospitals as soon as possible based on the positive feedback we've had from nurses. So that's it. That's our Smart Alarms project. Thank you so much for having us. And if we have time for any questions, that'd be great.
Thank you very, very much. That was very informative. I actually have a question for you guys. Can you talk a little bit about your EHR integration with the system?
EHR?
Electronic health records?
Yes, yes. So luckily, some much smarter PhDs are dealing with medical plug and play and how medical records can be downloaded to our device. But we did play with interpreting all the many forms of medical records so that the CDS and also the algorithm can output smarter results. So what's been tough for us is there's a lot of regulations as to what you can access and when. But our algorithm, at least for presentation purposes, assumes that you can access all that information to output more efficient alarms. But that's a great question. It's something we're dealing with.
Thank you very much.